questions. In terms of going abroad, I mean, any patient who's referred to the unit with a neuroendocrine tumour is discussed at a multidisciplinary team meeting. So at that meeting initially, whatever staging procedures, blood tests or biochemistry need to be done are first of all organised. The patient is then brought back for rediscussion again. If it is the case that that patient requires either imaging abroad or requires treatment abroad, then that's also discussed at the multidisciplinary team meeting. Derek, generally speaking, takes the lead in terms of sending patients for lutetium treatment or PRRT abroad. And as Derek presented there, we have used several units, and the reasons for that Derek might go into. So to answer the question, yes, we are sort of the gatekeepers of that, but it is discussed in a multidisciplinary context, and every neuroendocrine patient that is actually referred to the unit comes through or is discussed, be that a neuroendocrine tumour of the appendix or be that a midgut carcinoid with liver metastatic disease. In terms of the sort of rationalizing or making a patient's life easier in terms of getting through the investigations, this is a difficulty. I mean, we've discussed this, I think, previously at one of these meetings. What we have tended to do from patients that are travelling long distances, be that from Cork or be that from Clare or be that from Limerick, that we actually end up having to admit them. So we bring them in on a Monday, we try and get the Octria scans done or the MRI scans done or the 24-hour 5-HIAAs done while an inpatient rather than trying to do this as an outpatient. There are difficulties with that. There are problems, as you very well know, in terms of bed access within the hospitals, and it's often the work of our clinical nurse specialists working with the admission sister in the hospital to bring these patients in. But we do try to get the tests done in a timely manner and in if you like, a one-stop shop. So I hope that answers the first two questions.
Well, the applications come in, as you know, and they go to Dermot, who is our medical advisor. If we see applications coming in from a recognised name, then often as not, they may not even go to Dermot. They will just be approved straight off. Because we've got Dermot as the medical advisor, there's no issues with regard to any approvals for NETS patients. Not that I'm aware of anyway, unless anyone wants to tell me different.
Catherine has been outstanding. I mean, I've had no patients refused. There are a few colleges who don't work directly with the NET group, but would work in close consultation. For example, somebody up in Mayo who's linked in with Greg, who sends his apologies as well. Gregory Leonard, superb oncologist who was in Waterford, now I was in Galway, and he's looking after patients. They've got great knowledge in this field, and we liaise very, very closely. But one of his colleagues got in touch with me while Greg was away, and within 48 hours it was approved. I got a letter. I may have sent down a text just to say that you'll get a fax down, and sometimes they go through email because in fact it just speeds things up so much. We're really conscious of that, and we don't want you to be delayed in any way. And what happens? Just to explain. So we make a decision in Cork at the MDT, and Derek and Christor and the colleagues sort of say, well, this seems like a reasonable thing for a patient who's got good uptake on the Octria scan and they've maybe progressed to some treatment. Let's get in touch with Barbara and her group and Dan, etc., or the guys in Rotterdam. And I'll just comment on that in a second. But anyhow, so we sort of say that seems like a good idea. The patient then has to go to a website or just contact the treatment abroad scheme, and there are different numbers for different locations. It's very easy, it's on the first page. What I do in the outpatient clinic is now that we print it off so that we do it there and then we fill out the form. Then there's a letter. A letter has to go, and this is part of the treatment abroad scheme. It's not Catherine's governed here. This is actually the Department of Health who decided, and this is the process. So there has to be a letter that I would write to Barbara or to Derek or to Dan or one of the colleagues in Uppsala or one of the colleagues, for example, in another country if we're going for a diagnostic test. We have to sort of write to them and say, this is what we're looking for. Can you help us out? The patient, we think, needs this. So there's a form and a letter. Now, there can be a little bit of a gap between the form and the letter, but we try to keep that down to a minimum, okay? And the people in Kilkenny as well are aware of that, so we try to. But in fact, I think that, while there was a little bit of difficulties at the outset because we were using this on a fairly regular basis, that whole thing has become streamlined. We probably can streamline it even further, but it really, it's great. and it works well for me anyhow. It works really, really well. I think it's important that we explain to people the process at the outset. And some people don't have internet, etc., so we print them off and we can sort of facilitate that better. I think also that in Vincent's we're looking at trying to have a secretarial component to our group who is constant, and I think that's really useful, because if you have a secretary working with the net group and they're constant people, it means that all you've got to do is just send off an email. Can you have the form ready for such and such patients coming in on Friday morning, and we have it all ready, and that just sort of speeds it all up. You can even anticipate a letter going forward. I think the point about having different teams and different teams involved, I don't see it as a problem at all, Derek, I have to say. I think that's really good. It means that we've got access to different places for different types of treatments, different types of diagnostic procedures. That we as a network are visible in Europe is really vital for many different options, and I think that's great. It doesn't always suit perhaps to go to Uppsala, and there might be something else going on. There's been a few patients recruited into clinical trials, which is a hallmark for quality in this area, but and I think that we're just grateful to have all those options. There are lots of issues that we have to improve on, and I'm not saying that it wasn't a priority, but it's certainly with the mammoth tasks that were sort of ahead of us at the outset, we had a lot of things to tackle. And it is something that we need to address, because you're going down to get a blood test. I had a patient yesterday who came in to me, and I had to apologize to him. It said on it, I got up the computer, chromogranin, sample not suitable for analysis, right? And I just went bananas, because the patient group have been in talking to the biochemist who was in charge of the bloods. Somebody new down in phlebotomy, and even though we write on the form, it's written on it on ice, chromogranin on ice. I write on it personally, or Lisa writes on it, or whoever writes on it on ice, and the patient tells them on ice, and yet it's still not suitable for analysis, and we don't know why that happens. Now, it's happening far less often. It is a problem also coming up on the day with urine. What we try to do, for example, doesn't always work, but most of the time now, so you're coming back, let's say 6 months' time, or 9 months, or 12 months, or even a year, for whatever, year and a half, for a CT scan, and we try to coordinate it so you bring the urine with you on that day, especially if you're coming from far away. If you're living in our catchment area and you can come in on another day that's suitable for you, that's fine. We give you the container, there's a little bit of acid in it, you've got to be careful with it, and collect urine in the way we have with the leaflet. But in terms of blood tests and others, I agree, we need to centralise it, and it's been very hard. But if I can just sort of comment on that, Tommy, outside of the net field, it's a catastrophe. Some patients in private hospitals are getting the stuff sent for a fortune to bioMérieux in Bordeaux, right? There's a fantastic 5-HAA analyzer in James's. The people in biochemistry don't want to send it to James's. I don't know why they don't want to send it to James's. If you ask for genetic studies, we don't know where it's going. And it's trying to sort of get them together to centralize all bloods for various different diseases and illnesses. It would make sense. It would make financial sense. And it's very, very hard to tackle that, because they all have the different ins and outs. But we're certainly trying to tackle it from the net group, and we're going to work on that even harder.
I mean, just sorry, one other thing about sending patients abroad for treatment. As you know, a lot of the units have very, very strict criteria and need up-to-date imaging, Octria scanning, they need a Chi-67, they need up-to-date biopsies. They'll often review what you send them first of all, and they may write back to you and say, well, we're not happy with the imaging, can you repeat that, or can we get up-to-date imaging on it? So that what we send to them is often rediscussed at their MDT team, or reviewed by them first of all, before then the patient is accepted to go to that unit. So there is actually a lot of paperwork involved at our end in terms of getting the information together to make sure that patient is accepted for treatment abroad.